I just wanted to thank you so much and express my deep gratitude to Dr. Goodnight, as well as to Dr. Bold, the whole department, and Keely as well. Thank you so much for coordinating this visit. It's really an honor. I mean, honestly, I'm so humbled. And to think of the legacy and the work that is associated with this lectureship is really remarkable and very humbling. So thank you so much. All right. Thank you. Thank you so much. So as Dr. Bold mentioned, I'm a breast cancer surgeon at MD Anderson, and I've been very fortunate to be involved in the operative standards for cancer surgery, and so I wanted to talk about those with you today and how they can really advance our care in oncology. So these are the learning objectives for the talk. And to put it in context, really this is the work of countless surgeons and staff and decades-long, contributions from many, many others that are not here today. Dr. Nelson, who's the medical director of the ACS cancer programs, and Dr. Hunt, I think, were the kind of visionaries for the operative standards, and Dr. Katz has also been really a remarkable leader and champion for development of the standards as well. And so really under their leadership, a lot of this work has been done. And in 2020, a new cancer program under the American College of Surgeons Cancer Program was established, which is the Cancer Surgery Standards Program. And so at that time, I was able to be involved as the chair of the Education Committee. So I feel very fortunate to have made really a small contribution in this space. So just in talking about the rationale for operative standards in cancer surgery, so we do know that standards can improve, or improvements in compliance with evidence-based guidelines can help to reduce costs, reduce complications, improve long-term outcomes, and as well as increase patient satisfaction. And the research has shown this. And when we think about kind of what our contemporary oncology practice and care is, it really is very multidisciplinary team approach. There's a team approach, but really still at the heart of our multidisciplinary care is surgery. And there are even many patients who may even be cured with surgery alone. But cancer treatment is becoming increasingly complex, very personalized, targeted, as we even heard this morning. And this even makes our surgery and operative technique that much more critical. And looking back, evidence-based standards that guide our practice really have focused more traditionally on medical management. And so as Dr. Bold mentioned, this is what led to really an assessment of trying to define and address the gap that there is a lack of defined process standards for operations and the actual technical components that are known to have an impact on the patient outcome and oncologic outcomes. And so that's really what led to the development of the operative standards. So what is an operative standard? So an operative standard are really the critical elements of the operation that are associated with the oncologic outcome. And this involves the technical conduct of cancer surgery from the time of skin to skin. So not preoperative and not adjuvant, and even not necessarily other process measures like antibiotics. And this operative standards really help to set a minimum standard. So it's not that this is the maximum that really should be achieved, but at the very basic level, these technical aspects should be performed. And so these standards were developed in a partnership with the ACS cancer programs, as I mentioned, and the Alliance for Clinical Trials in Oncology. And they assembled teams of disease-specific experts who identified the critical elements of the operations in their area and then ranked them in order of oncologic importance. And then they went through a very dedicated and rigorous process, which was comprehensive, systematic, and methodical, to search the literature, review it, and to form recommendations based on these critical elements. And, as we can all imagine, there were very many areas of controversy or areas where there was no consensus among the experts. And in these cases, the team developed key questions in also a very methodical fashion, which are areas for future study. And so, I'm a breast surgeon, so some of my examples will be related to breast cancer. But here you can see the operative standards for breast cancer for partial mastectomy, axillary lymph node dissection, and sentinel lymph node dissection. And you can see that these are the critical elements that are important for each of these operations. And then kind of doing a deeper dive, let's say for sentinel lymph node dissection, one of the critical elements is identification of all sentinel nodes. And so these teams identified a recommendation that they reported the type of data that was used to make this recommendation and then the strength of the recommendation. And then also in the text, they include the rationale behind the recommendation. And over the past decade, this work has been done for 15 disease sites and really collected in these operative standards for cancer surgery manuals that have been put forward by the college and the Alliance Clinical Trials Cooperative Group. So what's some of the data behind operative standards and their ability to improve oncologic outcomes? So this is a study that was done in breast cancer looking at adherence to surgical and oncologic standards and how it impacted survival. So this was a national cancer database study over an 11-year period, and they categorized patients based on different clinical factors, the T stage, T1 to designate early breast cancer, D2 and 3, and then more advanced breast cancer as N2 and N3. And when they looked at 3 standards that were assessed, including the resection margin status, the number of lymph nodes examined, and here you can see that they expect at least 2 for the early stage disease and over 10 for patients who should have received an axillary lymph node dissection, as well as adjuvant therapy received. They actually found that across these different subcategories of breast cancer patients, only about 65 to 68% met all 3 standards. And then they took a deeper dive into each one of these standards and found that at least over 20% of patients did not meet the standards, the individual standards either. And when they looked at 5 and 10-year survival outcomes, comparing the group who was treated according to the standards and the group who was not, they found significant differences in survival, as you can see here. This is for the patients with the T2, 3 disease, and then for patients who were node or had locally advanced nodal involvement. And also, as you can see kind of in the bottom corner, the median overall survival in this patient population was dramatically different as well, 109 months in patients who were treated according to the standards compared to 73 months in the other group. And that, I think, if I did my math correctly, is about 3 years. So it can be very significant, even something as straightforward as adhering to the operative standards. This has also been shown in other cancer types as well. So for example, in rectal cancer, completeness of the total mesorectal excision is critical to ensuring optimal outcomes when it comes to recurrence as well as to survival. So really, it's not just doing the correct operation, but also the technique that is important as well. And lung cancer, looking at the NCCN guidelines, which recommend anatomic resection, negative margins, examination of hilar lymph nodes and mediastinal lymph nodes, at least 3 stations. Investigators found that when these standards or guidelines were adhered to, all 4, there was improved survival in those patients as compared to when one of these was not met. And so these studies and others have really started to add to the body of evidence that operative standards really can improve oncologic outcomes and really have kind of propelled this forward. So as Dr. Bold mentioned, I think that really the critical time was when the COC, Commission on Cancer, adopted the operative standards for accreditation purposes. And this really allowed the standards to be operationalized into our clinical practice. And so I'll just talk a little bit about them in more detail. So as I mentioned, in 2020, the COC adopted 6 operative standards focused on nodal surgery for breast cancer, wide local excision for melanoma, and colectomy for colon cancer. total mesorectal excision for mid to low rectal cancer, and then lung resection for lung cancer. And this only pertains to operations that are being done for curative intent. And this data was really driven from the operative standards for cancer surgery manuals that I previously discussed and the evidence base that had been previously designated and outlined. I should mention that this was really the first time that accreditation had focused at all on the technical conduct of surgery. And so this is really quite transformative and revolutionary in some ways. I think just highly critical and important. So in looking at the standards, the COC has outlined two aspects for surgeons to meet compliance. So one is that the operation should be done according to the standard, which is really one of the main parts we can control. And then the second part is to ensure that the documentation is done in a synoptic format that captures the specific elements, those critical elements that drive the cancer outcomes. And so you can see here for sentinel lymph node for breast cancer, the elements are here in the table. The operation was performed for curative intent. Tracers were used to identify the sentinel nodes, and then you can see that the response elements indicate exactly which ones meet that standard, and so on and so forth. Oops, sorry. Similarly, for axillary lymph node dissection, you can see here the standard applies to patients who are being treated with curative intent. It should include removal of level 1 and 2 lymph nodes within the anatomic triangle of the vein, the serratus, and the latissimus dorsi, and with preservation of the main nerves of the axilla. And the operative reports for axillary lymph node dissections should also be documented in a synoptic format, highlighting each of these elements. Here is the standard for wide local excision for primary cutaneous melanoma, which follows in a similar fashion. The standard states that the skin and overlying subcutaneous tissue to the fascia for invasive disease or to the subcutaneous fat for in situ disease should be performed, and that the margin width is based on the original Breslow thickness. And then these elements need to be documented in synoptic format, as mentioned earlier. And then finally, for colon resection in a similar fashion. And so for those four standards, the way that this will be measured is based on the synoptic operative report. And so this, I think, is really also another transformative aspect of the standards, and I'll talk a little bit more about it. But as you can see that even now, our sites should be documenting a plan for how to implement the synoptic operative reports, and that starting next year, site visits will look at data from 2023 to assess compliance. And so this is going to be rolling out in a stepwise fashion, and it's not meant to be something that's, sometimes I think accreditation or evaluation can be meant or can seem punitive, but that's really not what this is meant. This is just meant to demonstrate that the operations are being performed to meet that minimum standard, and without assessing or measuring the data, it's impossible to know. The standard 5.7 and 5.8, which deal with total mesorectal excision and pulmonary resection, are actually evaluated based on the pathology reports. And so these look at in a synoptic format. And so, these still are very highly relevant and important for the surgeon to perform the technically correct procedure and meeting all the critical elements. But it does also rely on a pathologist to be able to capture this information in the synoptic format. And so because of this, these standards actually went live earlier. So they sites are currently being evaluated based on data from 2021 to assess if they meet compliance with these standards. So I won't go into this too much, but there is a process around the site visits, and within our group, we have worked with the COC to not only try to educate around the technical aspects as well as the synoptic operative reporting, but also around what the process looks like to raise transparency and awareness around that as well. And so actually it's been like a very interesting process, I would say, initially with a lot of anxiety that was out there in the community. But over time, as we've been able to help raise awareness and support implementation, I think that there's a lot of value in this process, and that's being demonstrated and seen more frequently. So some recommendations around implementation, which is really the challenge. I think most of the, in a lot of cases, the operations are being performed to meet the standard, but it's really about how to, collaborate across the system and about the synoptic reporting. So some of the things that we have recommended and that sites have done is to do a self-audit, so to look back at their own data from years that are not going to be assessed to try to help identify where the gaps are, barriers, and areas for improvement. Like, for example, is there one surgeon who maybe is not documenting and capturing the information in the same way? And oftentimes it may just be that they're unaware, maybe they're new to the practice or something similar. So really trying to identify for the local environment what the issues are. As with any other interdisciplinary effort, it's really important to gather all the stakeholders, and this can include the cancer liaison physician, who's kind of the lead at that site, definitely surgeons, pathologists, as many of the standards do rely on pathology, cancer registrars who are really responsible for collecting or abstracting the data, IT. Without IT support, it's really not possible to do the synoptic reporting, local administration, et cetera. So working together in these teams can really help to improve the process and implementation. As I mentioned, sites are required to develop a formal plan for synoptic operative reporting, and we also are encouraging what we call like a pre-implementation of the use of these operative reports to identify opportunities for improvement as well. It's really, when I think about it, kind of the model for quality improvement, to identify and create a plan, to look back at the data, identify the gaps, create a plan, and then to implement it, study how it is, and then to assess if you need to make any changes. Okay, so just a couple words on synoptic operative reporting. Do you guys use synoptic reporting here at all? Okay, so you're already probably ahead of the game. But this was definitely new to me in a lot of ways. So synoptic reporting really is taking standardized data elements that are structured into like a list. And each element has a value that is able to be filled in, and it's a pre-specified format. And this is to ensure that there's no difference in the information that's being potentially entered from person to person. And this information should really be standardized, and you really should not be able to put in anything that's not within this pre-specified format. And the kind of beauty of synoptic reports is that it allows the information to be collected systematically, and every time it's stored, retrieved, and then it can be an automated process to gather that data back. And so in comparing narrative and synoptic reports, many of us, I think, look at the operative report in a very traditional, almost historical way, in the way that we dictate the report. It may or may not use certain terminology. My note may be very different from another surgeon, even my own group. It's in a prose format, and it's very easy to leave something out if you, just it slips your mind or you forget. Synoptic reporting, however, always has these predetermined data fields and responses, and so really it creates a tool. And it always uses the same language, and it's in the same format, and so it allows for that discrete data capture. And also it allows and ensures that data is not missed. And really we can look to our colleagues in pathology to understand more about synoptic reporting, because the College of American Pathology has implemented synoptic reporting for pathology. And this is a systematic review that looked at 33 studies and evaluated the completeness of reporting in a narrative or in the synoptic format. You can see the narrative in the darker bars and the synoptic in the lighter bars. And they found that there was a more accuracy in the synoptic reporting across the board. And I think that, as cancer surgeons, we can definitely agree. The pathology from our operations is hugely critically important and guides, if we need to do any additional surgery, any adjuvant therapies, and even just for the ease of use to communicate information to the surgeon, a narrative pathology report where you have to search for information and it may or may not be included is definitely not an ideal situation compared to the synoptic report, as you can see indicated here, where it's very easy to find, what was the margin status, how big was the tumor, et cetera. And so a lot of lessons can really be learned from CAP. This is a systematic review and meta-analysis that was done on synoptic versus narrative operative reports. And really what the authors found was that synoptic reporting increased the completeness of the required reports. It also increased the accuracy, reduced errors, and created more high-quality reports. And so these studies and others are really starting to outline, in some ways, the value and benefit of synoptic reporting to capture information. And some of those include the improved accuracy of documentation, to improve the efficiency of the data entry as well as abstracting the data after. It's a tool that can be used to reinforce education. We can talk a little bit more about this. It may also help to reduce variability in care by capturing the same data for each operation. And ultimately, with all of these, for all these reasons, can really help to improve the quality of cancer care. It can also help to inform better our research and which would make it more meaningful, the outcomes that we find and the findings that we find from research that guide clinical practice. So there are three methods and ways that synoptic reporting could be done now. I won't go into it too much, but it can be set up at the institution level. There are commercial options that are there, and then also the COC does have a kind of catch-all way for programs who don't have these options, where there's a PDF form that can be filled out. And ultimately, this is just the first stage of synoptic reports and synoptic operative reporting. And really, over time, as more standards are being determined and more synoptic report content is developed, eventually we'll get to the point where there may be universal implementation of these synoptic reports. And these would allow for data sharing. It can allow for abstraction and really hopefully, improve the quality of the reporting as well as improve the quality of care. And so I just wanted to spend a few moments talking about what I think could potentially be the impact of the operative standards. And this is just based from, my own personal reflections from the past couple of years being involved in this program. And so I just wanted to start with a case to kind of help illustrate the point. Hopefully it comes through. But let's take a patient who's a 36-year-old woman with an early stage breast cancer, ER positive, PR negative, HER2 positive. And so this patient receives chemotherapy. She has 6 cycles of TCHP and, eventually elects to have a lumpectomy, segmental mastectomy, and sentinel lymph node dissection. And you can imagine a scenario, this exact patient in one hospital with one surgeon who is familiar with the operative standards and has studied them or been trained. And in that situation, the patient undergoes her sentinel lymph node with dual tracer technique. There's very diligent review of the axilla, identifying 4 sentinel lymph nodes. 2 are found to be positive. She ends up having an axillary lymph node dissection. She ends up having adjuvant radiation to the breast and including the regional nodes. And then, because she was found to have residual disease, also will get adjuvant TDM1, which is has been shown to have improved outcomes in patients who are HER2 positive with residual disease over Herceptin and pertuzumab alone. So, that's scenario 1. Then you could imagine literally the exact same patient in a different situation where, maybe the operative standards are not known, and the patient has a sentinel lymph node biopsy with the radioisotope only. and one sentinel lymph node is identified, which in some cases happens. There's not always more than one sentinel lymph node. But let's say it was just done quickly, one sentinel lymph node identified, it was not positive, the patient had radiation to the breast, and she continued with adjuvant trastuzumab and pertuzumab. And although this is a hypothetical scenario, so the patient may have been completely appropriately treated, we do know that with only one sentinel lymph node, there is an increased false negative rate, and especially after neoadjuvant chemotherapy. So it's just something to consider, what could be the impact of these standards, even for one patient, and then you magnify by the, thousands of patients that are being treated. I think also that case just highlights how complex our multidisciplinary care is, and how critical really the outcomes from surgery are, whether they're clarifying the staging if there's residual disease or otherwise. So I think that, the operative standards really intuitively have a great potential to improve patient care. Certainly through improving quality of surgery, certainly through improving quality of staging, adjuvant decision-making, as I mentioned. They also can really help to reduce variation across the board. This can be within an institution or across the country. And potentially they may be able to even play a role in reducing disparities that we see based on cancer care that are really evident in every discipline, unfortunately. Another real big impact is with research. So as I alluded to earlier, actually the operative standards were born out of observations by Dr. Nelson and Dr. Hunt when they were evaluating clinical trials and evaluating the outcomes, but could not, saw a lot of variation in the surgical technique and sometimes even a, black box of not knowing what exactly happened. And so really these standards can help to ensure data capture and collection, also completeness, as we talked about, and they can really make our clinical trial data more meaningful. So if we have meaningful data that's coming in, it'll inform the outcomes and the findings of the research that's coming out, which would then also, kind of be cyclical, advancing our science and further refining techniques and care. Also, it really takes us from this current method of abstracting data, so, which takes a lot of human, effort, to go through charts, to find data that may or may not be there, to pull it out, to allowing for this process to be automated quicker, with more of an auditing function. And then really there are even next level advances with technology, with AI and clinical informatics that, I'm not sure I'm the right one to talk about, but definitely, there is a potential for that as well. So really it can revolutionize our research as well. And then lastly, and just to take a couple moments to talk about education and training, which is definitely, a passion area for me. I think very intuitively the operative standards can teach technical principles. So at the basic level, it definitely has a role in, our residencies, our fellowships, et cetera. This can, bear itself out in direct patient care. And also, the operative standards can be helpful to residents and fellows in other ways too. Like, for example, when you're preparing for your boards, really needing to know those critical elements for each operation. And then something that we've talked about at MD Anderson and really was kind of spearheaded by one of our fellows, Dr. Lilimo, and as well as the Surgeon Program Director, Dr. Grubbs, is looking at the operative note as a tool for education. So I don't know how you guys do it here, but I think that in a lot of places in residency and fellowship, really it's the faculty that dictate the operative notes. And nobody, I don't think, really teaches you how to do that. You just learn from either seeing or reviewing previous notes. But it is something that we can use to ensure that trainees are understanding why an operation is performed, as well as what exactly happened, and in a very structured format, and even give the opportunity for them to create the document and use it as a tool to reflect and to provide teaching. So there is really, I think, a high impact for education and training utilizing the operative standards. And so when I think about like what the scope of this impact could be, it's just, I don't know, it blows me away. So the COC has over 1,500 accredited programs that, and together, this treats 70% of all cancer patients in the country, which is really remarkable. When we think about clinical trials and research, we have thousands of clinical trials for cancer, just thinking about how this could potentially impact those. And we have, at least, I think around 1,300 to 1,400 general surgery residents a year, and then adding the other surgical subspecialties, and how this can impact, each of our trainees and their future, their careers, and the patients that they will go on to treat. So I think that, we're just, it's just in its inception of what we can really see and achieve from this program. Just to highlight some available resources that have come out of our committee. So we have worked really to, like I mentioned, to try to educate around the standards, around the program, around synoptic reporting, and around the process, and tried to be a support for surgeons and programs and registrars. And so we do have videos, webinars, visual abstracts, and other resources to be able to share. This, I love these visual abstracts because I think that they're, or I guess infographics, because I think that they're able to just very quickly distill exactly what you need to know, which is about the standard, about how it's going to be assessed, and about when. And so these are available and can be utilized to raise awareness, as well as to be a reminder of what should be done in each case. And then we do have a toolkit which houses all of the resources. So it's organized by topic, and it has really literally anything that has been developed from the operative standards and cancer surgery standards program. And so it's just a wealth of knowledge, and I just include it for your reference. And I'm actually getting towards the end. It looks like we'll have a lot of time for questions. But in summary, these standards were developed really to address a very significant need that was lacking, and to define critical elements of a cancer operation that was known to impact oncologic outcomes, and could really be, making sure that we're using the same language across the board. 6 of these standards have been adopted by the COC 2 years ago, and so this will really help to drive forward the operative standards in clinical practice. Synoptic reporting can improve the completeness of documentation, efficiency, as well as how we abstract data. And so this is really vital to ensuring that we have clear data and also are able to analyze it in a systematic way. And really, I think that, time will tell, but I think that there's really the potential and really a large scope for the operative standards to transform, our clinical care, research, as well as our surgical training. And I just wanted to include this slide to highlight that this is not, I'm here to present, but this is really work that's done on behalf of countless people, including, here's our whole committee. And we do have residents and fellows on our committee, as well as registrars and practicing surgeons. And so if anyone is interested in getting involved, there'll be a call out through the college, and please feel free also to reach out if you have any questions or anything further. All right, so that's all I have to share. I don't know if there are any questions or thoughts or anything that I can clarify.
So thank you very much. It was a pleasure having you. We do have a small token, TSA safe. travels well.
Oh,
But
thank you.
as our appreciation for coming, visiting us, especially with all of the changes of the last 2 years, we really felt honored to have you kind of educate us and I think really set the field of surgery on a path toward really consistent care that really is tied directly to outcomes. So I appreciate that.
Oh, thank you.
One quick question for the residents. So has anybody really had any honest education in what goes in an operative note? Just a hand, No. Okay, so I think this really well illustrates that impact. We're going to open it up to questions. I saw Dr. Goodnight scribble some thoughts as the lecture went on, and I'm going to offer him the chance to come first to the microphone.
Well, Teshome, it's lovely to have you here, and so instructive to hear this. I was delighted I understood the lecture. For a couple of decades, obviously, standardizing surgery improves outcome, it improves costs. It's reassuring. As you were talking, I was thinking the NSABP trial that matched a axillary dissection with radiation of the axilla, no dissection, or no treatment of the axilla at all. And the survival curves are all the same. And we knew in that group that didn't have any treatment of the axilla, there was at least 20% positive nodes. And so it led to a certain measure of nihilism and so forth regarding that. It's really reassuring to see these carefully done trials and standardization that very careful attention to the details of surgery actually does improve outcome and so forth. So here we are in the first part of the 21st century, and the quality of surgery still matters greatly. Will you, in this burgeoning activity, the ACS, the standardization, look at costs? I'm wondering if, in other words, if you more carefully do that initial breast surgery, fewer returns to the OR to pick up margins or failures and so on and so forth. Pretty hard to do, but a question, will you be picking up cost data at all somewhere?
That's a great question. Not to my knowledge, but I'm sure that as, even as I was getting ready and preparing for this talk, I thought of at least like 3 other research questions to look at. So I think that there's probably more to come on that for sure. Yeah.
Oh, wonderful. So nice to have you here. Thank you.
Thank you so much. I really appreciate it. I'm honored.
And Dr. Mel.
Mediget, it's great to see you and hear you and find out that you're really flourishing, and congratulate you on all your successes and wish you more in the future. My question is a medical legal one. So I've sat on national committees where we set guidelines for vascular surgery, and there's been these conversations about whether or not to use standards versus guidelines, and there's concerns that if when the word standard is used, then it may put people at medical legal risk. So I guess my question is, once these standards are published, especially knowing that there are outcome differences if the standards aren't met, to individuals, is there any concern, or has there been any experience that individual surgeons, individual cases where those guidelines haven't been met, that surgeon is at medical legal risk? And as a related question, what do you do if the path comes back and you haven't gotten your 2 lymph nodes for your stage one cancer, or your margins are positive and so forth?
Yeah, I think that's a really good point. Definitely, let's say to your last question about what do you do in that situation? I mean, like I mentioned, for breast cancer, anyone here who's done a sentinel lymph node dissection, you can't always find more than 1 sentinel node. Some patients, that's really all there is. But I think that if it's clearly documented, then that, makes, can kind of bring that to light as to why. And even in the standards, in the response elements, they do have usually a response that's not applicable. So there is a way to document, if something wasn't needed, or and so I think that, I don't know if that fully answers that part of your question, but that's kind of what my thoughts are. For medical legal, definitely the op note is a medical legal document. And I know that in looking at and creating templates, like a lot of those issues around compliance and the other aspects that need to be included in an operative note, as well as some kind of crosstalk between the AJCC staging and NCDB, and all these different things have been thought of and incorporated. I don't know specifically about to answer your question about the specific language between standard and guidelines. But I guess my thought would be that even in a synoptic operative report, there's still ability to usually use free text or something to explain. And really, this is, as long as you're documenting it, in some ways you're meeting the standard. Does that make sense?
Yeah, and just a quick related question. There are different techniques for the pathologist to actually mark those, check for those margins and collect lymph nodes. There's this ongoing conversation. They didn't find enough lymph nodes. Call the pathologist, please look for some more lymph nodes. And there are different techniques. Is there standards with regards to that to make sure that the lymph nodes are actually all identified in a specimen?
Yeah, I think, in these operative standards, it's not necessarily so much about the number of lymph nodes harvested. It's more like, for example, even for, sentinel lymph node dissection, how you inject, what tracer you use, how you inject, how you, perform the operation. Same for even the lung standard. It's looking at the different hilar, stations and mediastinal stations. So I know that especially even around that standard, there's a lot of education and work that's being done, and you do really have to work with the pathologist, because what if you take out tissue and you send it and they don't, identify any nodal tissue? Does that meet the standard or not? So I think some of those questions are still being answered. To be honest, even since the rollout, a lot of questions have been clarified, and I think that's what quality improvement is in a lot of ways, is just this continuous refinement and assessment. Yeah.
Dr. Roman.
Thank you so much for presenting. For whatever reason, since starting residency, I've had a passion for EMR documentation, and my residents will laugh at me every time I say this, but efficiency in documentation and data collection, I've just always inserted myself into those scenarios. And I don't really have a question. I just am. It's so exciting to see you present. And I'm being completely honest. And I just wanted to shout out. And I'm going on my research year in a few months. And so if any attending or service wants to explore this, please feel free to email me, and I will help get this incorporated into more of our op notes.
Escort you away from this Dr. Ramadan, and get
But
there.
thank you again for coming.
Well, you may consider, there's, this field of
Don't encourage him.
clinical informatics, and for example, one of our surgical oncology fellows did a fellowship in clinical informatics, and so she was very involved at her residency program with synoptic reporting, and as well as at MD Anderson. So that may be something to consider. I mean, it's just what drove it home for me is the comparison of the CAP synoptic report to the narrative report. I mean, and all of our attention spans, it's just not this, we just need the information we need. It needs to be relevant and available to everybody quickly. So it's still in some ways prone to human error. But I think, you have if this is your passion, go for it, because you have a great future, because this is just, I think, the tip of the iceberg. Is he joking? Is he joking? Okay, are you serious?
No, I'm
okay.
Yeah,
well,
I'm
I'll
serious.
put you in touch with her, because maybe
Okay.
you could learn, more about it from her too.
Great, thank you so much.
Thank you.
Dr. Utter.
Very nice talk, Dr. Teshome. So in a lot of ways, there have really been two big forces in the quality measurement field. One kind of more globally on the side of, basically CMS, the government, to enforce quality both from, the standpoint of both processes and outcomes. And then, of course, you have specialty organizations like the American College of Surgeons is a great example that really have kind of a different take. And those spheres really haven't coalesced. Is something like the synoptic operative note and these standards, are they sort of finally, a way in which those two forces will coalesce? In other words, you're probably aware, but CMS is aggressively pursuing not just administrative data-based quality measures, but now EMR-based ones, electronic clinical quality measures. And so I'm just interested in your thoughts on that.
Yeah, no, I think it's a great question. I think, to my knowledge, as the standards program was kind of developing synoptic op reports for different disease sites, I know that they were very intentional about including a lot of the data that would be needed for just regulation as well and compliance from either CMS, like we talked about medical legally, as well as through like kind of with the crosstalk for AJCC and the NCDB, so that things that were inputted could be easily captured and exported. But so I think that there is definitely potential for more alignment and more collaboration. Honestly, it's like way above my head for sure. But I think as there's more awareness, more of this is in practice, more of those conversations will be occurring.
So, Dr. Utter, I'll step into another role and the answer is unfortunately yes. So commercial payers are beginning to look at payment based on compliance with these documented procedural aspects of medical care. And while initially they're talking about using a carrot approach in terms of rewarding payments based on compliance, because they at least justify it by saying we're doing it to advocate for our patients' outcomes, the full intent is that it probably will become punitive, just as every other CMS initiative has removed from a reward system to a punishment system, and it's already on the horizon. So thank you for bringing that up.
Yeah, I know. Just interject just briefly. I'm a trauma acute care surgeon, so I mean this starts to have some interesting twists when you think about like colon cancer, and you don't know what you're operating on when you start the procedure, and then to try to adhere to standards, and maybe there will be different standards for operating for diverticulitis or whatever else. So
no, it's a great point, and I think that's why it's very intentional that these standards are for an operation that's being done for curative intent. So it's not meant for like a patient who's being treated for palliation or in like an emergent situation like that. I don't think that it would necessarily apply.
Yeah, elective preoperative diagnosis of cancer, I think. So thank you very much. This is a wonderful presentation. I have a quick comment and then a question. The comment is I appreciate your committee transitioning lung cancer from total lymph node count greater than 10 to actual stations, which is what we understand. So for instance, for example, because the lymph node count was totally subjective.
10 lymph nodes.
In our program, we got our NCDB report, annual report, and we showed we were in a lower percentile for lymph node count, even though we thought our technique was excellent. So all we did was we sent each lymph node individually in a cup, as opposed to a lymph node station packet. And we went from one of the lowest percentile to one of the highest percentile for lymph node count without changing our technique in any way. So that highlights the subjectivity of being relied upon by our pathologists to actually take the time to go through and get the individual.
Dr. Mel's point. Really.
Yeah. The second is, so the Commission on Cancer covers about 70% of cancer lives within the United States. And then has there been thought about, we touched on, we don't train our trainees on a proper operative report. A more intentional intervention from your committee, possibly working with the Academy of Master Surgeons or Surgeon Master Educators to develop a formal curriculum to instruct our trainees on operative. We don't even dictate anymore. We do dot, phrase,
yeah.
populate. But for operative notes that covers all of these things that will affect their reimbursement when they go out into the community, as we've heard. And that 30% that's not covered by the Commission on Cancer will be covered by these individuals who are recruited out of training to increase the level of care in our rural and underserved populations and other entities that aren't Commission on Cancer.
Yeah, no, thank you so much for that question and comment. when I first got involved, that's kind of where I saw a lot of the focus from this committee, the education committee of the CSSP. But actually, really, what kind of took more of a urgent need was educating, even just specifically around these COC standards, and then synoptic reporting. And so, really, our committee is really focused on all of the operative standards. But the residents, and we have a couple fellows that are in our committee, we did think about kind of a long-term vision, and I don't know if it will ever come to pass, but of even like the fundamentals of laparoscopic surgery, fundamentals of endoscopic surgery, something similar, operative standards for cancer surgery, whether it's for every trainee or whether it's for those who are very interested in cancer to kind of, set that groundwork. And then I think that to your point of educating around the op note, this is something newer that has come up, in our discussions. And one of our fellows wants to do, a small project kind of centered around this. But it's something we don't teach. And actually, I was thinking about, even when I was a resident, how one of my faculty shared, that he felt that a lot of times he would encourage us to really write thoughtful assessment and plans, because he was like, it's residents, you always focus on the HPI and, all these other aspects, and don't really focus on the part that really all the consultants are going to read. And it's kind of the same thing, right? Like when I was a resident, or even as a fellow, we didn't dictate notes, but you focus on the things that you know. So it may not always be the things that are the most important, like what suture or these kind of different things. So I think that there's a wealth of opportunity there around educating and around working with other surgical education societies.
Well, great, thank you.
Thank you.
And Dr. Ecker.
Thank you. Thank you so much for being here and sharing this really important work. I can definitely see the potential for what this is sort of going to unravel as in the coming decades. My question is around potential unintended consequences regarding access to care, which I think has been touched on a little bit in Dr. Cook's question and Dr. Mel's question about, are surgeons going to, in the community, back away from doing these procedures, operations at all, because of these added documentation, quote unquote, burdens, which may not actually be that burdensome, but maybe for someone who's out in the community. Is there any, are you gathering data on, just actual numbers of surgeons that participate in these programs? And then, as it was hinted at, the 30% that aren't covered. And how are we ensuring that we're not, or how can we focus on maximizing patients' access to the operating room? Because it's fantastic to improve their outcomes once they get there. But if we're delaying, we here at UC Davis, we get patients who travel, 6 hours away to come and have a cancer operation. How are we, looking at that aspect of the care delivery that's a little more upstream? Thank you.
Yeah, no, I think it's a great question. I don't know if the operative standards will honestly be able to answer it, because they're very focused on the technical aspects. But definitely access to care is a huge issue, and honestly, I think has even in some ways gotten worse or more exacerbated, like with the pandemic. I think that, to surgeons self-selecting out of operating for these cancers because of doing the operative standards, I mean, honestly, I think it would really be a shame, because if we do have data that shows that there's improved outcomes, and it's really, I don't know, the documentation or something that takes you away from wanting to do what is the best thing for the patient, then maybe, anyways, maybe that's, what should happen, I guess. But I think that really, truly, in every surgeon's heart, everyone wants to do the right thing for our patients and do the best that we can for them. And I think that, to be honest, a lot of, I'm pretty sure that in this department, probably all these standards are already being met. It's really, the challenge is kind of doing the jump towards the synoptic reporting and capturing. But as we all know, if you don't capture, you don't even know if it's happening. So I think in some ways we have to start somewhere. And with any program, there are sometimes unintended consequences, as you mentioned. But if we're continuously, like, diligently looking, then hopefully we'll be able to find those and address them. And then, we do have colleagues in the COC and other institutions as well who are really focused on trying to capture that percent, or, that population of cancer patients that are not being treated at COC accredited facilities. Like, for example, one of our colleagues, Dr. Lizaraga, she's at University of Iowa. That's like her passion area in terms of rural surgery and improving COC accreditation in those communities. So I think that there is definitely work that's being done, but these standards are just so narrow, they may not be able to really address that, question.
That brings us to the close. Thank you very much for honoring us with an amazing lecture and setting what we think is probably going to be improved care for our cancer patients. Thank you very much.
Thank you, Dr. Bull.